Hello, my name is Dr. Dewan S. Raja. Today I will discuss about diabetic nephropathy. Diabetic nephropathy is a chronic kidney disease caused by long-term damage from the diabetes, both type 1 and type 2. It is one of the most common complications of diabetes and the leading cause of end-stage kidney disease worldwide. Advanced or end-stage kidney disease occurs in as many as 40% of both type 1 diabetes and type 2 diabetes. The kidneys are prime targets of diabetes. Renal failure is second only to myocardial infarction as a cause of death from this disease. Three lesions are encountered: glomerular lesion, renal vascular lesions, principally arteriosclerosis, and pyelonephritis, including necrotizing papillitis. So there is glomerular lesion, so filtration process will be lost. Renal vascular lesions, so kidney will go through ischemic condition, lack of blood supply to the kidney. Kidney will be atrophied gradually. Pyelonephritis, that is an inflammatory process, initially start in the interstitial tissue, then those involve the renal tubules and will get involvement of the renal papilla with necrosis leading to necrotizing papillitis. Diabetic nephropathy develops due to hyperglycemia, persistent high blood glucose level, cause oxidative stress and damage to the kidneys, filtration unit known as nephron, hypertension, elevated blood pressure further damages kidney vessels, inflammation, and fibrosis. In a patient with long-standing diabetes, there may be development of hypertension. And usually patients are old, so a lot of them have already essential hypertension. So that will add with that of the pathology of diabetes that will damage the kidney further. Chronic inflammation leading to scarring, glomerulosclerosis of the kidney disease tissue, proteinuria, loss of kidney's ability to prevent protein leakage into urine. If we go to the histopathology of diabetic nephropathy, we'll find key histopathological features: thickening of the glomerular basement membrane. So we'll see the basement membrane is very much thickened, mesangial expansion and proliferation of cells in the glomerulus will get mesangial expansion. Okay, surrounding part will get mesangial expansion. Nodular glomerulosclerosis, Camel tail Wilson nodule will get nodules. Okay, if you look at this electron micrograph renal glomerulus showing marked thickening of glomerular basement membrane B in a diabetic patient. Okay, so we get glomerular capillary lumen here, urinary space here, urinary space. So as a whole, there will be damage to the filtration part of the kidney system. So we got, this is the lumen here, lumen of the capillary. We have the urinary space here. We have the mesangial tissue here. There will be nodule there. Okay. If we go next slide, histopathology of diabetic nephropathy. Diffuse nodular diabetic glomerulosclerosis by Pass stain. Diffuse increased mesangial matrix here, mesangial matrix, and characteristic acellular Pass positive nodules here. Here we'll see renal cortex showing tubular basement membrane thickening, is the tubule, renal tubule, and this basement membrane thickening. If we go here to the kidney, nephrosclerosis in a patient with long-standing diabetes, kidney has been bisected to demonstrate both diffuse glomerular transformation, the surface left, and marked will see the granular transformation, not glomerular, granular transformation of the surface, and marked thinning of the cortical tissue on the right side. Cortex is thinned out. Additional features include irregular depression and also cyst as a result of pyelonephritis, and an incidental cortical cyst. We'll get some cyst here, cyst, cortical region, and this is granular. As well, cortex will be atrophied. These are the features of the, and kidney size will be decreased due to lack of blood supply, and kidney is going to be non-functional eventually. These are the features of kidney involvement in long-standing diabetes. What are the symptoms? Early stage are often asymptomatic. Symptoms develop as kidney function decline include microalbuminuria, early marker, presence of small amounts of albumin in the urine. In a normal person, healthy person, the urine should not contain protein. Only during pregnancy there may be trace of protein. But in case of diabetic nephropathy, there will be microalbuminuria, an early marker. Gradually, there will be proteinuria, large amounts of protein in the urine as the disease progresses, swelling. It may be more than 300 milligram per day. Swelling, edema, especially in the feet and ankles. High blood pressure, fatigue, weakness due to anemia, and uremia in the later stages. Anemia because kidney damage, there will be lack of erythropoietin, lack of stimulus to the bone marrow to produce the blood cell, particularly RBC. There will be uric acid accumulation in the body, that lead to uremia. Okay. Stages of diabetic nephropathy. Diabetic nephropathy is classified into 5 stages. Hyperfiltration, increased kidney filtration initially because of high glucose in the blood. Microalbuminuria, small amount of albumin in the urine. Overproteinuria, detectable protein loss in urine. Decreased glomerular filtration rate, progressive loss of kidney function. So the filtration membrane now cannot work. It is going through changes, pathological changes, thickening, also mesangial proliferation. The capillary damage will cause decreased glomerular filtration rate. ESKD, end-stage renal kidney disease, end-stage kidney disease, require dialysis or kidney transplantation. This is the last stage. Management, blood glucose control, maintain hemoglobin A1C less than 7% through lifestyle changes and anti-diabetic medications. Blood pressure management, target blood pressure should be less than 130 by 80 millimeter of mercury. ACE inhibitor, that is angiotensin converting enzyme inhibitor, or angiotensin receptor blocker, are preferred to reduce proteinuria and slow progression. Dietary modification, low protein diet, consult a dietitian. Sodium restriction, so no table salt. Okay, salt should be minimum, no additional salt. So that should control blood pressure or help in the maintenance of normal blood pressure with the medication, certainly, and will not cause deterioration of blood pressure, hypertension. Management of diabetic nephropathy, lifestyle changes, smoking cessation, regular physical activity, medication that will protect the kidney, like SGL2 inhibitor, that is enkephalin and GLP-1 receptor agonist for kidney protection in diabetes. So these are renal protector, SGL2 and GLP-1. Treatment of complication, diuretics for edema, erythropoiesis stimulating agent for anemia, advanced therapy include dialysis or kidney transplantation in end-stage kidney disease. Prevention of diabetic nephropathy, optimum blood sugar and blood pressure control, regular screening for albuminuria annually in diabetic patients, early use of nephroprotective agent, what we discussed. And that's all about diabetic nephropathy. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.